Hi, everybody. I'm Raj Mago. I'm editor-in-chief of simpleandpractical.com. And I'm very pleased to be here today with Dr. Leslie Citrome, who is an internationally recognized expert in psychopharmacology. He's clinical professor of psychiatry at New York Medical College. He is the president-elect of the American Society of Clinical Psychopharmacology. And we are very proud that he is on the editorial board of simpleandpractical.com as well. Thank you, Dr. Citrome, for speaking to us today.
Oh, my pleasure.
So this is National Eating Disorders Awareness Week, and Dr. Citrome is a leading expert on eating disorders in general and binge eating disorder in particular. So I requested him to please speak to us a little bit about binge eating disorder. So Dr. Citrome, firstly, what is binge eating disorder? It's confusing because as I was saying to you before we started, I sometimes think hey, do I have binge eating disorder? Because I do sometimes overeat.
Yeah, it's a good question. I first encountered this when I started my private practice. For years I worked in the public mental health sector. And I worked first with the VA, then the New York State Office of Mental Health, did research did clinical trials in schizophrenia, but I always had a private practice. And in this private practice, I started out by taking referrals from two social workers who specialized in eating disorders.
Okay.
So I became a de facto clinical eating disorder psychiatrist, very different from my day job, but I had to deal with it. I had to learn about it. And it's interesting because the most commonly encountered eating disorder then, and still is, was binge eating. And at that time, there was no diagnostic code for it. We were used to hearing about anorexia nervosa,
Right.
bulimia nervosa, but never binge eating disorder. It was always like this miscellaneous category. But basically, most of the patients that came to me, yes, they had their comorbid depression, their comorbid anxiety, but they would eat a lot of food in a short period of time and feel very bad about it. They didn't necessarily purge. Now, they were usually overweight, but not always. And we didn't have a word to describe them. Turns out now, DSM-5 introduced binge eating disorder as recurrent episodes of eating a lot within a short period of time, more food than what most people would eat, and a lack of control. So it's this lack of control that really defines that binge. So you or I may eat, a lot of our favorite foods quickly and perhaps a lot of it, but we never really lost control. And that's
I
the
don't know
key.
about that, Dr. Citrome. Sometimes I do feel, sometimes I do feel that, but I'm sorry that I interrupted you, but it seems like many mental health problems, it might exist on a spectrum, right? Like people can have a little bit of something, but then at a certain point it becomes a disorder. Would you say that's true for binge eating disorder also?
Well, there is part in the definition has to occur at least once a week for 3 months.
Okay.
So there's that definite threshold of frequency and duration. It also has to be associated with marked distress.
Okay. Mm-hmm.
So if I didn't care about it, I'm not sure how much of a disorder it would be. Typically, people with binge eating disorder have a lot of distress over their behavior.
Yeah.
And it's occurring actually far more frequently than once a week. And it's lasted a lot longer than 3 months. And they definitely have a lack of control. So it's not like, let's say, Thanksgiving, where it's socially acceptable to eat a lot. This is eating a lot and doing it more often than one would like. So losing control more often than one would like. I think that's one way of looking at it. And the associated features of binge eating disorder are actually quite interesting. Eating more rapidly than usual, eating until feeling uncomfortably full, eating large amounts of food even when not feeling physically hungry, eating alone because of feeling embarrassed about how much one is eating, and feeling disgusted with oneself, depressed or guilty afterwards. And you need at least 3 of these 5 associated features. And very often people with BED have all 5. So you may eat a lot sometimes, but you don't meet all the criteria.
And I eat because I feel hungry. Sometimes I feel very hungry. So, but these people you're saying some are frequently eating, like even if they're not hungry, they're eating for some psychological reason.
Yeah, so they can eat a lot even when not hungry. So they have lost their sense of control over what they can eat.
Right. Right. Okay. And you also mentioned about the feeling uncomfortable. So the eating, I'm like, when I'm eating, at least at that time, it seems like I'm enjoying myself. Versus for these people, it might be
Oh,
they're
you
not
keep on
enjoying.
going. Keep on going until you can't, until you can't. So here's an anecdote. A person who is normal weight actually looks very physically fit. He's a physical trainer. He's a man. He doesn't fit the prototypical BED patient, yet he had real bad BED. He would be obsessed with thoughts of food, and he would compulsively eat. So it's also obsessions about eating and compulsions about eating. And he couldn't, help himself. When he described when he would see a breakfast buffet, it was like a shark attracted to blood. That's how he
Yeah.
described it.
Wow.
And he would spend actually a lot of what he earned as a physical trainer on fast food. Extraordinarily large amounts of money spent on
Wow.
food. Now, because he's a personal trainer, he's able to work off those extra calories. People who don't do that will ultimately gain weight.
Right, right. Okay. So this is really very quite different from like other people overeating, and you were seeing this as a syndrome like even in your private practice even before the DSM-5. DSM-5 was the first time that some binge eating disorder was introduced in 2013.
Yes, and so we didn't have a word for it. It's like non-purging bulimia. But
Yeah.
there's no such thing in the DSM about non-purging bulimia. The best we can do would call it eating disorders not otherwise specified, EDNOS. I remember when Professor Walsh, he's one, Timothy Walsh at Columbia, he's one of the giants in the field of eating disorders. He gave a talk at a conference in the early 90s when I was getting started in my private practice, in addition to my day job with the state and the feds and so on. And I was struggling with how to deal with these patients and what to call them,
Yeah.
because there was nothing in the DSM that would help me. He gave a presentation on binge eating disorder and how he was advocating that it be included in the DSM-4. That was never adopted in DSM-4 other than in the research appendix.
Right.
Now, I remember writing him a letter in the early 90s saying we must have a diagnosis of VED that's official. How else am I going to explain this to my patients
Yeah.
and have them feel, you know, that they do have something that needs treatment, and feel that their symptoms are validated in some way, that what they're going through is real. Because very often people think it's a moral failing, that, it's not really an illness. It's like a failure on their part of being a person.
Right. So what do you say to the patients with binge eating disorder? What tips would you give to clinicians in terms of how they should educate their patients about what binge eating disorder is?
Well, first off, I would, acknowledge that binge eating disorder is common and that it exists in our practice, whether we recognize it or not. About 1% of the population would have binge eating disorder, so not negligible. And amongst those coming for psychiatric treatment, it would, of course, be higher. So,
Yeah.
how do we find out who these people are? They're not going to tell us. They're ashamed of what they're eating. Plus, they don't see it as an illness, they see it as a personal failing. So they won't tell us. It's a secret. Their families don't know about it because they eat in secret. They hide those food
Yeah.
wrappers.
Yeah.
They eat when no one is with them, and it's a secret.
I
So
saw I saw, I'm
unless
sorry,
you,
I saw a patient who would go into the bathroom and she would eat in the bathroom so that her spouse would not find out that she was
yeah,
eating. I've
yeah.
seen another patient who would take all the wrappers and like with the packaging of the food with her in the car and go and drop it off in a dumpster somewhere else so that it wouldn't be in the trash in the house. And her spouse also for a long time did not know that she had binge eating disorder.
It's very common. People will eat in secret. For men with binge eating disorder, they'll hide their food in, like, where their workshop, for example, if they're into, woodworking or, whatever, there's a fridge there. Well, why is there a fridge there? Well, for drinks or whatever. But, that people put food in places where they can get at it later. So it's a crime of that's planned. It's also a crime of opportunity. So if there's extra food around, they can't resist. So I have a patient who will eat whatever's in the house, basically. And it's difficult when the husband, let's say, buys stuff like ice cream and cookies and chips, whatever. She'll eat that. So finally, thank goodness, they've stopped doing that. But she'll eat a lot of yogurt, a lot of fruit. Doesn't really matter what the food is.
I see. I see. So it doesn't have to be high calorie food. Now we
No.
are using some of the examples we gave were of women, and certainly I think binge eating is more common in women, but it does occur in men also.
Yeah, absolutely. So men can have BED. When we look at the percentage of women versus men with eating disorders, the furthest apart in terms of percentages is, let's say, anorexia nervosa, where far more women than men have it. It's a lot closer for BED.
Okay.
So it's not as many men as women percentage wise, but it's a fair number. It's worthwhile asking. So he had asked me, what do I do? Well, I assume that exists in my practice. And in my routine evaluation of people, I always ask about their eating. Now, we do that anyway. We ask, how's your appetite? How's your sleep? How's your concentration?
Right.
Rolls off our tongue. It's routine. It's part of our standard question. So I add actually another aspect to eating. So, how's your appetite? Now, tell me, while we're talking about food, do you ever eat more than what you had expected to eat? And did you ever lose control over what you were eating? Takes 2 seconds to ask that. And sometimes they'll say, yes, that happens to me. Then you follow it up with the other questions regarding binge eating disorder. Your yield will not be like every patient will endorse this, but not every patient endorses problems with sleep, appetite, concentration, or
Right.
like suicidality. Very few. Yet we always ask those questions. So we can ask about food, not only appetite up or down, but how they eat. And that's the key.
So do you think that would you agree that if clinicians, psychiatrists, nurse practitioners, psychologists, if everybody asked all their existing patients about binge eating, would you agree that they would be surprised to find that they already have patients who have binge eating and they didn't know that? Because God knows that has happened to me.
I guarantee it. It happened to me too, and I'm an eating disorders guy. And it happened to me with one of my private practice patients. I should have known better. But she came to me with a major depressive episode. Turned out
Oh,
she had major depressive disorder
yeah, yeah.
with a lot of somatic symptoms. And I helped her with that. But over the years, she kept on gaining weight. And she would always complain to me, I'm gaining weight and yet I'm on this diet and it not working. And I was clueless. I should have asked. So, what are you eating? How are you eating? Do you ever lose control over what you're eating? Ultimately, I did ask her that. And she
Yeah.
said, yes, that's exactly what's happening. And then I read her the DSM-5 criteria for binge eating disorder. And she was flabbergasted. She said, yeah, I have all those things.
Yeah.
That's a
So,
disease?
so we have to ask women and we have to ask men, young and old. What about like do are most of these patients obese? Do we need to ask these questions only of patients who are overweight and obese, or could the person be of normal weight and still have binge eating?
There's a substantial minority of people with BED with normal weight or just a little bit overweight. Now, of course, obesity is common in people with BED, especially as they get older. These calories catch up with them, and they're not able to get rid of those calories as they used to be when they were younger. So that's a fact. But you can be of normal weight and have BED. That physical trainer who I described had normal weight. So you would never know. You have to ask. But people who are obese, it's a must that you ask this question. And that's why these bariatric clinics, prior to operating on them, they always screen for BED because
Yeah.
that will predict failure to the bariatric surgery. So they all screen for BED, and the odds ratio of having BED if you're obese is much higher than if you're normal weight. But doesn't mean you can't have BID and be normal weight.
So it seems like we really this should be one of the, given that it's 1% of the population. I mean, schizophrenia is 1% of the population, and and we don't want to be missing that. So
1% of the general population.
yeah,
It's
and
probably much
higher,
higher in your
higher in,
practice.
correct, correct. So I think I love to say behooves. I like the word. It behooves us to screen every person, man or woman, young or old, obese or non-obese, because because again, would you agree that our ability to predict that this person probably doesn't have binge eating disorder is not that great, and the only way to know is to ask?
Absolutely. It's a secret disorder. People don't talk about it. They won't bring it up. It's like sexual dysfunction. Will they bring that up? No, no way. So you have to ask directly about it. And when you ask and they answer and they have it, they are grateful that you opened up the conversation,
Yeah.
and then something could be done about it. Same with eating disorders, especially BED.
Do some of these patients do these patients come to the clinicians for binge eating disorder as the problem, or do they come because they have depression, anxiety, some other problem, and binge eating is like the hidden part of it?
They, in my own experience, it was very rare that they would come only for that. But then again, I would get referrals from the two specialists in eating
Yeah.
disorders, and they would refer to me those with comorbidities. But in my practice of self-referrals from the community, no one self-referred because of eating disorder. They always came for depression or anxiety.
Right.
And then came along the BED when I asked about it. So comorbidities are very common. BED rarely occurs in isolation. And if you look at the percentage of people with comorbidities, it's the majority, the vast majority. I think 80% of people with BED have at least one psychiatric comorbidity.
Right. Okay. So I think that we have really emphasized this point very strongly, that binge eating disorder is present in our patients. They won't present with binge eating. They're probably not going to tell us. We really need to raise our awareness and be screening people actively, everybody. Can you tell us one more time, like how do you suggest screening? You did say that, but can you just emphasize again, how exactly should I screen? So if I have a patient who's come to me for depression and all that, what are the questions you suggest I should ask?
Well, I'm as non-judgmental as possible. So I don't use, words that might offend someone. And I try to put it within the routine, much in the same way we ask about libido, sex drive. It's a
Yeah.
matter of fact question. So when I ask about sleep and concentration and appetite, so how are you eating? Has you gained any weight, lost any weight? How's your appetite? They expect those questions.
Right.
Everyone
Yeah.
asks those questions. But I
Yeah.
followed up. So talking about your appetite, do you ever start eating and then can't stop? Does
Okay.
that ever happen to you?
So the loss of control.
Loss of control. And then if they endorse that, bingo, you need to ask the other questions. If I can actually mention here now, this is being broadcast during the Eating Disorders Awareness Week. And it just so happens that a special issue of Clinical Therapeutics has come out. It's dated January 2021, but actually came out in February, actually came out now. And in that issue, which is free to access, there are articles about binge eating disorder, anorexia nervosa, bulimia nervosa, as well as about the similarities and differences between obesity and binge eating disorder. And I urge people to go on Google, type in clinical therapeutics, eating disorders, and hey, my name, Citrome, Citrome. I was one of the co-editors of this special section along with Dr. Grillo, Professor Grillo at Yale. And we put together these articles actually with our audience in mind. So practitioners in mind, what would be useful to know? So free
Awesome.
to access.
Awesome.
And
I will definitely put a link along with this interview. We'll put a direct link to that. I downloaded it only this morning, and I started reading your editorial. I was reading, by the way, Dr. Citrome, I was reading that this disorder was described in the 1950s by a scientist whose name was Hamburger.
yes,
I
yes,
that is not a joke, is it? The,
it's not a joke,
the
but
scientist's name was Hamburger.
it's terrific because it allows me to start my lectures on a high note. I start with a historical perspective
Yeah.
of binge eating, and I say it's been described for over 50 years. First described in medical literature by Walter Hamburger. Well, what do you think of that? So it gets a chuckle, it puts people at ease,
Yeah.
and then they can listen to the rest.
Right. All right, great. So let's say, God willing, the clinicians who are listening will screen people, and non-clinicians, if they are listening, will talk to their doctors about this problem. What are the treatment options? Like, what are we looking at in terms of treatment options?
Well, there's basically two lines of treatment for binge eating disorder specifically. There are psychological interventions such as CBT, cognitive behavioral therapy, interpersonal therapy also, and they're geared towards the obsessions and compulsions regarding eating and the behaviors themselves. They're manualized treatments, so you need to be trained to give them. There's also some self-guided CBT out there, online self-guided CBT as well. And the important aspect of it is that it does work. However, it does not generally lead to weight loss. You do avoid the additional weight gain because people's behaviors have changed, but there's no weight loss per se. Now, access to a skilled therapist to do this with patients can be difficult.
Yeah, almost impossible. Yeah.
Yeah. Well, I wouldn't say almost impossible, but still not easy. And you also have to be motivated and insightful enough to participate. Not all of my patients are.
Yeah.
So that's one option. The other option is pharmacotherapy. There's one agent approved by the FDA to treat binge eating disorder, moderate to severe binge eating disorder, and that's lisdexamfetamine, a stimulant. And that actually works quite well. It's not always so easy to use. You need to titrate it. You need to make sure the person there's no abuse concern, diversion concern that would prevent its use. They need to be healthy cardiac wise and so on. There's some precautions there.
This is
And in
Vyvanse.
term,
This is Vyvanse we are talking about.
yeah, that's Vyvanse is the brand name, yeah. And in terms of tolerability, not so bad, except for dry mouth. Dry mouth is to be expected with stimulants, and some people just can't stand it.
Yeah. Yeah. So this is the only FDA approved medication for binge eating disorder.
The only
Um,
one.
and does work. I have myself treated several patients with binge eating disorder with lisdexamfetamine, and not all our disorders are treated so well, but certainly the patients I treated, it was a very dramatic, quick and dramatic improvement on relatively lower doses. Is that just my experience, or do you think that's true in general, that the doses tended to be, in my experience, the doses tended to be lower than for patients with ADHD? So in the 30 to 50, by 50 milligrams of lisdexamfetamine, my patients showed a complete resolution of the binges.
Well, it was tested in people with binge eating disorder with a target dose of 50 to 70 milligrams a day. And so that led to the product label recommendation of going to that dose range, no higher, no lower. However, people do titrate from 30 to 50 and then, possibly to 70. In my own experience, 30 is often potent enough.
Yeah.
And going higher just leads to more adverse effects. So I think it's certainly possible to see an effect at a lower dose. It just wasn't tested systematically in that way in the clinical trials that led to its approval. Now, I don't have enough experience with ADHD to opine whether or not, ADHD people need higher doses. All I can say is about BED, it's sometimes not necessary to go higher than 50. And sometimes you get lucky and 30 does work. The problem with, dosing lisdexamfetamine too high too quickly is it is really a tolerability issue.
Yeah.
And that really was limiting the use of topiramate for BED. Works quite well for BED, but paresthesias are very common. And almost every patient has a paresthesia. It can also cause some cognitive impairment as well. And dosing it upwards is somewhat of a struggle. And
Hundreds
people
of
don't
drug
want to
interactions.
continue taking it.
Right.
I'm sorry.
I'm sorry to interrupt you. Hundreds of drug interactions with topiramate, a 1% risk of renal stones. Yeah, so there are issues. I have certainly not used it yet for binge eating disorder. But do you think that this is probably a question they may not be a good answer to this. I was wondering if all stimulants would work for binge eating disorder, or because lisdexamfetamine is still branded, and although access has improved, but it still tends to be a little bit on the expensive side. Uh, do we have reason to believe that other stimulants would work as well?
So I don't know. Theoretically, why not? It's certainly worthwhile thinking about perhaps even trying, but they haven't been assessed in a systematic way, the way lisdexamfetamine was tested in randomized controlled trials for FDA approval for that indication. So it's actually a bit of an unknown.
Okay.
But if you don't have the ability to prescribe lisdexamfetamine, or for whatever reason a person can't receive that one, then I wouldn't give up entirely. And I would think, well, what else can I do that would approximate its potential effect?
Right. Because our expert interviews are seen all over the world, in more than 70 countries. So most of those countries may not have lisdexamfetamine specifically, but they may have other amphetamine preparations that they could potentially consider.
Yeah.
Um,
I want to say that it's a different mechanism of action than for ADHD. So with ADHD, what we want to do is improve executive functioning, help people focus and concentrate better. With BED, what you're getting at are the obsessive thoughts and compulsive behaviors regarding food. So subcortical structures are affected here, not cortical. Takes a little bit of time, but it's a whole different set of pathways, which have been hypothesized to be related to BED and why stimulants would work. So not cortical, subcortical.
So this is not simply that the appetite is being suppressed, because the binge eating disorder was not driven by appetite as the central problem anyway, as we discussed.
Absolutely right. So we can see a decrease in appetite and weight loss in people receiving lisdexamfetamine. And then there's some patients who don't have that, and yet they still have improvement in their binge episode frequency. So when you measure their obsessive thoughts and compulsive behaviors regarding food, looking at the Yale-Brown obsessive compulsive scale adapted for binge eating, you see reductions on both parts of that scale that correlate with the reductions in binge eating frequency. So this tells me that I'm not just dealing with the behavior, I'm dealing with something about the brain and the processing of thoughts. The automatic behaviors are being eliminated.
Right, right. Okay. That's very important to emphasize. And I think that maybe it would be good also to state that we are not encouraging, we're not promoting or suggesting that lisdexamfetamine should be used for weight loss, because some concern has been expressed in the literature that this medication has been misused for weight loss, and that is certainly not the purpose here. The purpose is to reduce the binge eating.
Right. So there is misuse of stimulants for weight loss, and the FDA was quite concerned about this when approving lisdexamfetamine for binge eating disorder. And so the manufacturer of lisdexamfetamine had to go out of its way to make sure the public knows this is not for weight loss, not approved for weight loss, wasn't tested for weight loss. In fact, they've never revealed the percentage of patients who have lost at least 5% or 10% of their weight. They won't tell you that. I'm sure they've calculated it, but they won't tell you.
Right, because they don't want to encourage that misuse, right?
Correct.
What about the duration? So the patients who do respond, how long should they continue on the lisdexamfetamine?
So they actually did a randomized withdrawal study. So they took patients who responded to lisdexamfetamine and then randomized them to either continue it or to go on to placebo. The relapse or recurrence rate, however you want to call it, for those who continued on lisdexamfetamine was very, very low. For those randomized to placebo, it was substantially higher. Correct me if I'm wrong. I don't remember exactly. I think in the 30s or something.
Yeah, I think it was about 5%, 27%.
Yeah, around that. In fact, I can pull up slides right now that would remind me of this, because this is actually important that we get this right. And so we have 32.1% recurrence or relapse rate for those on placebo, 3.7% for those who continued taking lisdexamfetamine.
Big difference.
That's a number needed to treat a 4. For every 4 people you keep on the medicine versus not, you avoid a relapse event. And for disorders that are quite distressing and impactful on psychosocial functioning, this is really quite important. And actually, it's quite an impressive effect size when you think about it.
Very impressive. Yeah. So you're saying that probably we don't know exactly how long, but we should be prepared that if the patient is a good responder, the patient will probably need longer term treatment, right?
I would think so. At some point, you're going to make a decision with them about, do you want to try going off it or not? And sometimes you'll get lucky and they'll be in that 70% or so that are relapse free, at least for a duration of time. You can always restart the medicine if you need to. We don't have any information about loss of efficacy if you have to restart it again. Sometimes we are worried about that with depression.
Yeah.
For example, I'm not sure that that actually exists for BD. I'm not sure if anyone has ever looked at it.
Right. Okay. Okay. What about the non-pharmacological treatment? How well does that work? And do we have any reason to believe that if we combine the two, cognitive behavior therapy and lisdexamfetamine, will that be any better than lisdexamfetamine alone?
Well, CBT or IPT work well. And I would say they are as robust as lisdexamfetamine in the reduction of binge frequency. So that's good news. So it would be logical to think about combining them. After all, we do that for depression, right? We combine psychotherapy with medicine and we get synergism. Actually, that was never established for BED. A number of trials were done looking at it. Only one was successful in showing superiority of a combination approach, and that was with topiramate and CPT. There has not been a study completed or reported that I know of that combines CBT with lisdexamfetamine that can make the same claim. So contrary to what we would expect, there's not really great evidence to say that together they're better than either one alone. Now, that special issue or section of clinical therapeutics contains a whole article that explores that in detail. So I encourage those who are interested to read that.
Very good. Very good. Thank you so much, Dr. Citrome, for it's very wonderfully emphasizing the important things that we need to understand about binge eating disorder. And I hope that this video will be viewed very widely and will raise awareness among clinicians of all kinds and in the general public at large also about binge eating disorder. And more of these people will realize that it's a real illness, not feel the shame, and be willing to seek treatment because very effective treatment is available.
Absolutely.
So again, thank you so much for speaking to us.
You're very welcome.